Now, the way I have prepared, I'm sure you have got the list what we are going to do today. The way I am going to run today, because I am almost a sole stand-up comedian talking to you for the next 2 to 2.5 hours. So what I'm going to do is I'm going to go for 55 minutes and then give you a break for say 5 minutes for asking question and a formal break for another 3 to 4 minutes for you to stretch. And then I'm going to go back once again. So the first topic that I have chosen today for your course is the neoanatomy of breast and its implication in management. Now you have all been through this anatomy of terminal duct lobular units and the lobules and the ductules, and I'm not going to take you through that. I am chosen these 4 areas which you as an upcoming breast surgeon must know. Number 1, what are the changes in the microscopic understanding of the anatomy of breast and the resultant breast cancer? Number 2, I'm going to talk about a completely new group of blood vessels that have been identified in last 5 years. These are the chest wall perforators and how it changed the perception of breast cancer. I'm going to take you through the mandatory anatomy of latissimus dorsi muscle, which is, I'm sure that is almost an universal tool for any breast surgeon, because that is going to help you bail you out in various circumstances. And finally, I will just discuss the lymphatic anatomy of the axilla and the arm. Now, coming first to the microscopic anatomy of the breast. Now, over years, we have been told that infiltrating breast duct cancer is a cancer which shows pleomorphic nuclei with scanty basophilic cytoplasm, with RTPA, with erased mitotic figures, and that's how a cancer look like. However, over years, as people have started deciphering the microscopic anatomy of breast, they came to realize that there are 2 groups of cells. It's not so generic to state that it is something arising from the terminal duct lobular units or from the lobules. See, it comprises of the inner group of cells which are called the luminal cells. And we thought that these luminal cells are the main cells which produces cancers. And we were fools to understand that some of them express ER and some of them express PR and some of them express HER2/neu. But as we deciphered the microscopic anatomy, we found that this is the basement membrane and this is the luminal cells, and squeezed in between the basement membrane and the luminal cells are a group of cells called myoepithelial cells. Now, these we thought were just cells which are affected by oxytocin. They make the tubules contract and secrete milk. And that was the idea in the last decade. But today we are able to understand that this is not really only just a cell which actually controls the contraction of the tubules or the terminal duct lobular units, but these are cells which modulate and protect the inner luminal cells like the parents outside, and they liberate large number of proteins which protect and prevent any atypical change that happens in the luminal cells. It also is responsible for creating the basement membrane beneath it. And if they can then create the basement membrane beneath it, it actually works as a barrier and does not allow the spread of an in situ cancer to an invasive form. And only when the basement membrane breaks that it will go inside. And this breaking of basement membrane is being protected by these myoepithelial cells. So today we must understand that we distinctly have 2 groups of cells, one which are called the luminal cells and the others which are called the myoepithelial cells. And behind that, is the curtain of basement membrane. Now, what we need to understand here is that based on this microscopic or electron microscopic anatomy, we were able to decipher that certain cancers which originate from the luminal cells are called luminal cancers, and they can be luminal A or luminal B. And there are certain cancers which arise from the basal layer, and these are the basal cancers or HER2 enriched cancer if they do not express ER and PR. And there are certain rare variations which are called the normal looking cells, and we have multiple subtypes of each of them. So as the cell of origin is different, and just try to understand, I told you that the basement membrane is the basic protection membrane for the spread of cancer, and myoepithelial cells are the paracrine cells which protect the luminal cells and keep the barrier or the wall, which is called the barrier or the wall, which is called the basement membrane intact. Now, if that is so, all the basal cancers are likely to be more aggressive cancers because they break and their protective control over the breast is lost. And the anti-apoptotic function, the anti-angiogenetic functions are completely lost. So therefore, you must understand the significance of this new group of cells, which are called the myoepithelial cells, and they are the key players or the kings in understanding of the breast cancer. The implications, therefore, is cancers behave differently depending on their cellular origin. Coming to the next part, the vascular supply of the breast. Now, we have been told over years that the breast is being supplied by small perforators from the chest wall, and we have been told that there are certain internal mammary perforators, and when we do a mastectomy, we will encounter medially, and tomorrow I'm going to show you a video, and you will understand the perforators that come out from the internal mammary chain on the medial aspect of the breast. But today, what new thing has been deciphered, or rather not a new thing, an old wine which have been placed in a new bottle in a completely new look, is the understanding of the perforators. Now you have the thoracodorsal pedicle, and from the thoracodorsal pedicle we have multiple vessels coming down, and these vessels, based on each vessel, they supply the overlying fat. And if you can preserve that particular vessel and the overlying fat, and at times overlying skin, you would be able to use that amount of tissue and rotate it to fill up any defect in the breast. So you see, you have here the lateral thoracic artery perforator, which comes out from this area and supplies this amount of breast, and this is the large amount of tissue that it supplies, including the overlying skin. So you can use this amount of tissue to fill up a defect that have happened here. You can also use the skin or overlying skin and rotate it to cover up a defect by a mechanism, just like the propeller of a helicopter or a small flight. So those propellers can be used to cover up defects. As you go down, you will have a set of perforators as the internal, I mean the intercostal vessels come out. You have the anterior intercostals coming up here. It again supplies a paddle or an island of breast tissue and the overlying skin. So you can use this perforator to fill up a defect. Far more medially, you are going to get the medial intercostal artery perforators, which supply the fat and the overlying skin, and therefore this can also be used. So guys, you need to understand that gone are those days where we looked into the breast as the axillary vein, and you look at the thoracodorsal pedicle and the classical radical mastectomy where you preserve these A, B, C structure. Those are gone. Even the small minor vessels play a major role in breast oncoplasty. Now I'm going to show you just in a small video, which I'm going to repeat tomorrow even, that how exactly locate a perforator. Here is a Doppler. With the help of the Doppler, we can locate the anatomy. I mean, you can hear the sound of the small perforator. And on your left, that you see is the type of movement that we do to locate the perforator. By this small movement,
size of the perforator, acoustic signal.
So once you hear the signal, that there is the location of the perforator. Now you see, this is another video by which you are going to understand how important it is to locate the lateral intercostal artery perforator. And look at the technique.
This is the handheld Doppler. We are trying to find a perforator from the intercostal artery. In the 5th intercostal space, it is aligned to the anterior axillary line. And we find a good perforator with a good acoustic signal. There are 2 nearby perforators here, as I can see. One having a signal. They are both nearby. Signal gets blurred when we move our Doppler pencil tip away from the perforator. Several other perforators like the T-tap artery perforators, which is found in the posterior axillary line, as I have marked, about 8 centimeter from the lower limit of the axilla can be found. These are very sizable perforators and flaps can be based on them. The advantage being that we don't need to sacrifice the latissimus dorsi. Extension to comma, the abduction. Here we are getting a signal. So this is one of the perforators of the thoracodorsal artery. And when we compress the signal goes away. When we compress or probe, the signal goes away. This is an indirect proof that this is a cutaneous perforator and not the main vessel or the main supply. Like this, we can Doppler map the whole area, and according to our defect, we can plan our flap based on this type of vessels.
So you understand how important in today's era are these perforators, and how with the help of a Doppler we can actually navigate the perforator. So remember anatomically 3 important perforator: the lateral intercostal artery perforator, the anterior intercostal artery perforator, and the medial intercostal artery perforator. And these 3 perforators almost encompasses a large portion of lateral, mid, and median aspect of the breast. Apart from that, we have the thoracodorsal artery and the lateral thoracic artery perforator, which can be used for the sake of reconstruction. We can choose to have a color Doppler also being done, and with the help of color Doppler we would be able to look at the perforators very clearly. And in today's era, learning the art of color Doppler and marking it to know where exactly the perforator is situated makes sense, because you are going to preserve the perforator as you do the surgery. I come to the third part of our discussion, that is the utility of the latissimus dorsi flap in clinical practice, a brief overview for beginners. Now, this is the anatomy which I want you to understand. Now, this is the whole range of the latissimus dorsi muscle, and you see it arises from this area. It is a part of the iliac crest, and it goes down up above onto the lateral aspect of the bicipital groove. And as you see here, the thoracodorsal pedicle comes, and I'm going to show you a better picture. It has its branches which supply from this side. It also has small lumbar branches which supplies from the medial aspect in the back. So basically it's a dual supply. And when we use this flap from this aspect, we cut the muscle from this aspect and rotate to put it up there. We utilize the thoracodorsal pedicle and its branches. Again, it's not so simple. That thoracodorsal artery is very simple artery. It's a complex artery. It gives off the circumflex scapular branch, and then the main thoracodorsal pedicle comes. But look here, in the down in the lower part, a descending branch comes, and this descending branch shoots off multiple branches on its anterior aspect. And this is the picture where you see it is shooting off multiple perforators in its anterior aspect. The advantage of having this perforator is that you can go beyond the muscle. It's not only, this is the muscle that you see, but you can go beyond the muscle. You can go beyond the muscle into the anterior skin, and you can get a large, robust amount of skin so that you can utilize it. And the main reason is because of the perforators that comes on the anterior aspect beyond the muscle and supplies the overlying fat and the skin. I come to the fourth part, which is the axillary and the arm lymphatic anatomy. Here again, I will show you two small videos. We have been told over years that everything that comes from the breast goes into the axilla, and based on which the sentinel lymph node biopsy was planned. And the other thing is that we have the arm lymphatics, which comes from the arm and goes up into the apex of the axilla. So what you need to understand, that these are two different rivers. One river starts from the breast and flows into the gulf of the axilla. The other river comes from the fingers and has a meandering course into the axilla, and then they finally go into the apex of the axilla. If by any means we are able to differentiate two groups of lymphatics, in 5 to 7% of cases, there may be a concordance. That means the arm lymphatics and the breast lymphatics, they come together in 5 to 7%. But in 93 to 95% of the cases, they are separate. And if they are separate by a technique, which I'm going to show you, a clinical anatomy, by which, now this is how exactly a sentinel lymph node biopsy is being done. I have chosen the ICG technique because it's real time and you would be able to see how the lymphatics flow. You make a small injection in the subareolar space and then you see what happens. Now we are injecting 4 of them at 4 corners, and then we are rubbing it a bit. And as we rub it, you see how wonderfully the lymphatic spreads goes down into the axilla. And then you can make a small incision in the axilla, open up the axilla in a small way, and then we can dissect it. That's exactly the sentinel node that we are talking about. And as I said, it can be so wonderfully delineated by this ICG technique that you would be able to visualize exactly how the lymphatics flow from the subareolar plexus down into the sentinel node, and then you can take it out. Now, this is one anatomy that you need to understand, that there are 2 rivers, one river which drains from the breast into the axilla, goes up into the apex, and there is another river which comes from the arm and shoots up directly through the arm lymphatics up into the apex of the axilla. So you see, we have taken out the sentinel node. That is completely separate. We will review the technique once again tomorrow. And this is the sentinel node that has been taken out, which glows once we see it or look it under ICG camera. Now we go to the next understanding is the arm lymphatic dissection. Here what we can do is, for your understanding, we can inject the same dye ICG into the wave space. We can also use the blue dye, but I have chosen ICG so that you are able to visualize it properly. And then you will understand how distinctly they have a different pattern of lymphatic flow. Now look at this. This is the arm streak of arm lymphatics that you see here going up, and it goes into the apex. This is no way connected to the lymphatics of the breast. And as we move it, we can actually play with the lymph node, and we can see we can actually preserve the arm lymphatics the way we want to do. As I said, in 5 to 7% of cases, there may be a concordance, that means convergence. But in generally 95% of the cases, as you see, the arm lymphatics is completely separate from the breast lymphatics, and therefore you can, with the modern technology, being able to preserve the arm lymphatics distinctly. You can actually play with the arm lymphatics the way you see in the video that I have displayed in front of you. It goes straight high up into the apex of the axilla from the arm. And you saw the lymphatic flow that we had of breast, which goes down into a separate group of lymph node and takes a altogether different path to reach somewhere. So any questions on this? Any questions? You can unmute yourself and ask me a question. Any clarification on the newer concepts of anatomy of the breast?